Hi everyone, this is Module 11. This week we're going to be talking about physical activity and diabetes. So diabetes, from a general sense, is when blood glucose or blood sugar is abnormally high. So this can be measured by taking a blood sample and assessing the amount of glucose or sugar in the blood. And you're probably aware of at least two types of diabetes. We call them type 1 and type 2. And then there's a third type that I want to discuss as well, which is called gestational diabetes, and this develops during pregnancy. So let's start with type 1 diabetes. This used to be called juvenile diabetes, and then there's another name for it, insulin-dependent diabetes mellitus. But usually this is just referred to as type 1 diabetes, and this is the diabetes that is not typically related to lifestyle. So this is what children most frequently, if a child has diabetes, it's type 1, but adults can develop it as well. This is when the immune system destroys the pancreatic cells, which are the beta cells, the cells that make insulin. And we'll talk a little bit about insulin and what it does, but insulin, of course, is a hormone, and its job is to regulate blood glucose. So if insulin doesn't work properly, then regulation of blood sugar doesn't work properly. So it usually strikes children and young adults, but it can happen later in life as well. And this is, in the grand scheme of things, fairly uncommon. About 5 to 10% of diabetes cases are type 1. And there's some evidence that type 1 diabetes is caused or is stimulated, I guess, by some type of immune reaction. For instance, there have been cases reported where people have maybe a spider bite, and then the immune system, of course, reacts to that bite, and then after that they'll develop type 1 diabetes. Things like that. That's not always the case. Sometimes type 1 diabetes develops for no obvious reason, but it does seem to have some type of immune component, but it's really unknown what causes type 1 diabetes. Risk factors can be genetic, autoimmune, or environmental. There does seem to be some genetic component. People with a parent who have type 1 diabetes are more likely, although it's certainly not guaranteed that they will develop this form of diabetes. Type 2 diabetes is what you're probably most familiar with, because most cases of diabetes are type 2. Usually this begins as what is called insulin resistance, where the body is resistant to the hormone insulin. Insulin, again, is a hormone that's released to lower blood sugar. So, unlike type 1 diabetes, where the pancreatic beta cells are damaged and they don't work, and the body doesn't produce any insulin, in type 2 diabetes, the body can produce insulin, at least for a while, but the cells become insensitive to insulin. They don't respond to it anymore. So type 2 diabetes is associated with being older, with being obese, having a family history of either type 2 diabetes or gestational diabetes, which we'll talk about shortly, being inactive, and certain races and ethnicities. Particularly, there's higher risk of type 2 diabetes in African Americans, Hispanic and Latino Americans, and American Indians. There have been studies done on certain tribes within American Indian groups, for instance, the Pima Indians, which are located primarily in Arizona. They have somewhere in the prevalence rate of 50 to 60%. So more than half of those individuals will develop diabetes in their lifetime. And the reason is not explicitly clear, but it seems to have some genetic component as well as probably a lifestyle, cultural component as well. But the point is that certain races and ethnicities are definitely at greater risk. The reason that type 1 diabetes can't be called juvenile diabetes anymore, unfortunately, is that type 2 diabetes is becoming more common in children and adolescents, so that term is misleading. So this is part of the problem with childhood obesity, is that the development of type 2 diabetes is increasing and happening earlier, and there are numerous health problems, of course, with diabetes. Diabetics tend to have eye problems. This is due to damage of the vasculature supplying the eyes, and then poor circulation in the periphery, especially the feet. So it's not extremely common, but sometimes diabetics with poor control of blood glucose end up actually having feet or leg amputations because the blood supply is so poor. Okay, so let's talk about what causes, or what the cause of diabetes is. So this is showing type 1 diabetes, where there's insufficient insulin production by the beta cells of the pancreas. Insulin's job is to cause the cells, mostly the muscle cells, to take up sugar. So if you eat something, let's say you eat a muffin, we'll just use that as an example. You eat a muffin and there's now glucose from the food in your bloodstream. That's represented by these blue particles here in the picture. So now you have glucose in your blood. Well, in order for your body to use that sugar as fuel, it has to take it into a cell that can metabolize it. Muscle can do that. So you have these GLUT4 transporters that sit on the surface of the muscle cell, and their job is to transport glucose into the cell. They can't do that, though, without getting a signal from insulin. And these green receptors here are insulin receptors. So what happens is that insulin responds when glucose levels are high. So if you eat the muffin, the body recognizes, oh, there's a lot of glucose in the bloodstream now. Insulin will bind to the insulin receptor, and that is a hormone signal to tell the GLUT4 transporter to open up and allow the glucose to enter the cell. So what happens with type 1 diabetes is that you don't have enough insulin. The beta cells are damaged, they don't produce much insulin, and therefore if you don't have insulin, you can't have this cascade that opens the GLUT4 transporters. So glucose builds up in the cell, in the blood, because it's not getting the signal to move into the cell. In type 2 diabetes, the difference is that there is enough insulin. It's just that the body becomes resistant to it. So there's plenty of insulin. What happens is that the insulin receptors basically stop working. They are so overstimulated. There's so much glucose, there's so much insulin all the time that they finally stop responding. Think of it as you may have heard about, I think it's like an Aesop's fable about yelling fire, basically. You don't yell that there's a fire unless there's really a fire. Why not? Because people will stop paying attention. If in elementary school the fire alarm went off every day, or in your dorm, maybe this happens, the fire alarm goes off pretty often, well, eventually you assume that every alarm is a false alarm. That's kind of how it works here. There's so much insulin signaling all the time that eventually the body just ignores it because it assumes it doesn't really need it. So the message from the insulin receptor to the GLUT4 transporter doesn't get passed along. So there's lots of glucose out here in the bloodstream that doesn't get transported into the cell. not because there's not enough insulin, but because the cells are resistant to it. So the end effect is the same. The effect is that there's too much glucose in the blood and not enough in the cell. And that is what you see here on the bottom half of the picture in the blue. With low blood glucose, the pancreas is still involved, but it's different cells. They're alpha cells. Alpha cells release a hormone called glucagon. Glucagon basically works exactly the opposite of insulin. It causes the liver to release glycogen, which again is just stored sugar. And that glycogen enters the bloodstream and causes blood glucose levels to rise. So again, all of this is to maintain a healthy, normal level of blood sugar. There's one more type of diabetes to mention, and this is called gestational diabetes. This occurs occasionally in pregnant women, and it's becoming increasingly common and increasingly problematic as obesity becomes more and more of a problem. It occurs more frequently among African Americans, Hispanic and Latino Americans, and American Indians, so you'll note that the same groups that have higher prevalence of type 2 diabetes also have higher prevalence of gestational diabetes. It's also more common among women who are obese or who have a family history of diabetes. This does need to be treated to regulate blood sugar, because what happens is that babies tend to get too large. They become very big babies and they're difficult to deliver. And about 5 to 10% of women with gestational diabetes will develop type 2 diabetes after the pregnancy is over. So certainly not everyone, but it is, they are at a higher risk. And then they have a 20 to 50% chance of developing diabetes within the next 5 to 10 years. So certainly avoiding gestational diabetes is important. So how do we know if someone has diabetes? This is the diagnostic criteria. So there are 3 different ways to assess or to test for diabetes, but the most common way is what you see in this first column, the oral glucose tolerance test. This is when someone consumes a certain amount of a high glucose, it's usually a beverage, so it's usually a very sugary, kind of like a Kool-Aid or a Gatorade. It tastes terrible, and they drink this substance, wait a certain amount of time, usually 1 hour, and then blood sugar is measured. So if the blood glucose is less than 140 milligrams per deciliter, that's considered a normal response to the tolerance test. Between 140 and 199 milligrams per deciliter is impaired, and if the concentration of blood glucose is greater than 200 milligrams per deciliter after that hour, they're considered to have diabetes. Usually you have to fail the glucose tolerance test twice to confirm the presence of diabetes. So this is showing how common or the prevalence of diabetes in various countries in the world. So this is the prevalence of diabetes for adults aged 20 to 79. And you can see that in the United States, right here, 10.3% of adults in that age range have diabetes. We are second only to Mexico in terms of diabetes prevalence. Iceland, Norway, the United Kingdom, Japan, those are some of the lower prevalence countries. The incidences in youth is particularly problematic. So this is showing the rate per 100,000 per year. So this accounts for age. The per year piece accounts for the age a little bit. But what you see is that in children under 10, almost all cases are type 1. There's the black bars are type 2. Very, very, very rare have type 2 diabetes in kids under 10. You see the groups here, all is everyone, and then non-Hispanic, white, African American, Hispanic, Asian Pacific Islander, and American Indian, I believe. But when you get over to the 10 to 19-year-olds, you start to see a much increased prevalence of type 2 diabetes, and that is what is particularly scary. The earlier someone develops diabetes, the more likely they are to have complications from it at some point in their life. Things like vision problems, neuropathy, which is due to poor circulation, and diabetics also tend to have a lot of problems with kidney function. So of course, this is all leading towards what is the role of exercise or physical activity in treatment and prevention of diabetes. So first I want to talk about type 1 diabetes. Unfortunately, there's not evidence that exercise can treat type 1 diabetes. So someone who's diagnosed, it doesn't mean they shouldn't exercise, but it's not likely to regulate their blood sugar. Of course, all people can benefit from physical activity or exercise. This includes type 1 diabetics, but they have to be particularly careful about hypoglycemia. Hypo, of course, means low, and glycemia refers to glucose. So low blood sugar can be a problem because, of course, when you exercise, your body is using glucose. That's a fuel that the body can use to supply the exercise. So they need to be very careful about letting blood sugar get too low. Most type 1 diabetics take insulin, and so they may need to take less insulin before they exercise. And this can be a fairly complicated process to figure out how much insulin and the dosage when they're going to be physically active. But it's very important that they are able to be physically active. We're going to spend most of the time talking about type 2 diabetes because this is the most common and the most changeable, I suppose. And the really good news is that exercise is a very effective treatment for type 2 diabetes, and it's also been shown to prevent type 2 diabetes. So what I want to talk about is first is how can it do that? So remember, you've seen this before. Type 2 diabetes is insulin resistance, where the insulin receptors don't signal the GLUT4 transporter to bring glucose into the cell. What exercise seems to do, and we're not going to get into all of the cellular processes that occur, but basically exercise bypasses the whole insulin system and directly signals the GLUT4 transporter to take up glucose. So again, bypassing the insulin receptors, more GLUT4 transporters move to the cell surface and bring glucose into the cell. So exercise is very effective at causing the cells to uptake glucose. This is true even with an acute or a single bout of exercise, one bout of exercise, going for a walk or a run or a swim. One bout of exercise actually increases the body's ability to uptake glucose. And of course, regular exercise is even better. So now let's look at some of the epidemiologic data showing the relationship between activity and type 2 diabetes. The first question is how does the amount of leisure time physical activity relate to risk of diabetes? So this is showing relative risk on the y-axis. So everything is being shown relative to this group, which gets less than 500 kcals per week of activity. And so you have this very nice dose-response relationship. More physical activity, which as you move to the right here, That's what you're seeing. More physical activity is associated strongly with a lower risk for type 2 diabetes. So what about the intensity? Does the intensity of physical activity matter? This data is from the Nurses' Health Study and the Physicians' Health Study. These are two cohort studies, obviously made up of nurses and physicians. And what you see here, again, is relative risk on the y-axis. The black bars are the nurses. They were all females. The gray bars is physicians. I believe that's males and females. And you see less than once a week. So people who get vigorous activity less than once a week, more than once a week, or more than once a week after adjustment for body mass index, which again is an indicator of obesity. So what you see is that vigorous activity does have a protective effect, and this is true even after you adjust for BMI. So this is demonstrating that, yes, more physical activity is better, like we saw in the previous slide, but the intensity of that activity matters also. So fitness also has been studied in relationship to type 2 diabetes risk. This is from the Aerobic Center longitudinal study, which you've learned about previously. And this is where all participants undergo a graded exercise test and all kinds of other assessments. And so they looked at people divided up by fit or unfit, and then normal weight, overweight, and obese. So the reference group here is the fit and normal weight group. And then you can see this is fit and overweight, and then fit and obese, unfit normal weight, unfit overweight, unfit obese. So not surprisingly, the group with the highest risk is the unfit and obese group. But this group is obese as well, but they have, being fit does protect them, certainly. This is interesting. In some of this data with fitness, you'll find that being fit is better even than being unfit and normal weight. But here you see fit, obese has a higher risk than unfit and normal weight and unfit and overweight. But again, being fit does seem to protect you at least somewhat from diabetes. So we've seen that diabetes is associated with less diabetes is associated with more physical activity. The next question is, can exercise or physical activity prevent diabetes from even occurring in the first place? The biggest study on this topic was called the Diabetes Prevention Program, and then this was done, it's been about 15-20 years now. What they did was this was a randomized control trial, and they had people put into 3 groups. They either were in a placebo group, a metformin group. Metformin is a drug that has been shown to effectively treat diabetes, and then a lifestyle group where they consumed a healthy diet and were physically active. And what you see is that over the 4 years, they did this for 4 years, and over the 4 years, you're looking at cumulative incidence, so the increasing incidence of people, more and more people develop diabetes over the 4 years. All of the people in the study were considered to be at risk for diabetes because of a family history. And so in the placebo group, almost 40% of the sample developed diabetes over the 4 years. The metformin group did have a reduced cumulative incidence, but not as much as the lifestyle group. So here is the same data shown a little bit differently. Here you're looking at fasting glucose, So remember, you want fasting glucose to be low. I'm sorry, you want it to be high because the you want, sorry. Okay, let's look here. The 1, 2, 3, and 4 are the years of the study. So this is after year 1, this is after year 2, 3, and 4, and then placebo versus metformin versus lifestyle group. So again, you're looking at fasting glucose. So this is the blood sugar level after not eating for a period of time. So after year 1, there's some difference, but fasting glucose levels went down in all 3 groups over year 4. This data shows it a little bit better because it's all in terms of relative risk. So this is a placebo group. This is the metformin group. So they have reduced, their relative risk is about 0.7, so about a 30% reduced risk. And the exercise and diet group, the relative risk is about 0.4, so about a 60% reduction in risk of diabetes. So that's incredibly large. Remember, these are people who are at risk of diabetes anyway. So we probably wouldn't see this extreme of a range in a sample that was not all at risk. But for people who are at risk of type 2 diabetes, because of a family history, exercise and diet is incredibly effective at reducing their risk. So the diabetes prevention program did show a reduced incidence of type 2 diabetes, an 11% reduced risk in the placebo. So even taking what they thought was a drug, it really wasn't. But even taking a placebo actually reduced risk somewhat, a 31% reduction in the metformin group and a 58% reduction in the lifestyle group. So this is really good news that, yes, diabetes is a big problem, but we know something that's very effective at treating it if we can just get people to do it. Next, I want to talk about the metabolic syndrome, which is very closely related to diabetes, but it's a little bit more encompassing of other conditions that are associated. So to be diagnosed with metabolic syndrome, you have to have 3 or more of the following characteristics. So the first is abdominal obesity, meaning excess fat carried in the abdominal region. This is assessed by waist circumference, the distance around the waist of 40 inches or more in men or 35 inches or more in women. A triglyceride level of 150 milligrams per deciliter or greater. HDL cholesterol, remember this is good cholesterol. So HDL less than 40 in men or less than 50 in women. Systolic blood pressure of 130 or greater, or diastolic blood pressure of 85 or greater, or a fasting glucose of 100 milligrams or greater. So, because of that last component, excuse me, this is related to diabetes, but it encompasses other conditions that are associated. So if you have 3 of these 5, of course you can also have 4 or 5, but if you have at least 3, you're considered to have metabolic syndrome, which puts you at risk for all kinds of health complications. So this data was looking at the relationship between not physical activity, but sedentary time. Is sitting or not moving associated with metabolic syndrome? So what you see is people who have either 0, 1, 2, 3, 4, or 5 of the criteria. And so you can see that this is looking at sedentary time in hours, so people who had 4 or 5 of the metabolic syndrome criteria did have slightly more sedentary hours compared to those with 0 or 1 or even 2. But the difference here isn't extreme. This is looking at sedentary time as a percentage of total time, but you see kind of the same thing. This was looking at the length of the sedentary bout. So all of these are just slightly different ways to look at the same thing. So what we see here basically is that sedentary time is maybe slightly associated with metabolic syndrome, but it's not an extreme, strong predictor. This is showing the prevalence of metabolic syndrome, specifically looking at men. So these are all Caucasians. This is Hispanics. So this is metabolic syndrome, meaning they have at least 3 of those criteria. Then it also shows all of the individual 5 criteria. And this is looking at inactive, irregularly active, and regularly active. So they defined inactive as reporting no physical activity. Irregularly active as less than the physical activity recommendations, but at least something. And then regularly active are people who met the physical activity recommendations. So for the metabolic syndrome, people who are inactive are more likely to have metabolic syndrome than irregularly active and regularly active. And there was a nice dose response there, and you really see that pretty regularly throughout the data in the Caucasians and the Hispanics. And then they also looked at African Americans. This is a little different because we didn't see that relationship as strongly here for metabolic syndrome in the African American men. And the reason for that really isn't clear. So this was looking at the relationship between metabolic syndrome and physical activity levels. So this is in the men all together. So I really want to just look at the metabolic syndrome and obesity. So these are odds ratios. So the reference group is the regularly active. And then you see irregularly active and inactive. The odds ratio for being inactive was 1.6. Irregularly active was 1.52. And you can see that for abdominal obesity, the numbers are actually pretty similar. So that can be interpreted as activity is protective for metabolic syndrome and obesity, but not to it's definitely helpful, but these numbers are not extremely high. It's important, but maybe not as exciting as we might hope. Okay, so one more topic to address is resistance training. This is a frequently asked question. Does the exercise need to be aerobic in nature, or does resistance training impact diabetes risk as well? So this is a really cool study where they looked at 32,000 plus men using a cohort design, and they did either resistance training, aerobic training, or both. So they just let the people do whatever they did normally, and then they asked them about it, and they assessed their risk of developing type 2 diabetes. And so this is the data. Alright, let me try to explain this slowly. First of all, on your y-axis, you have the relative risk. So everything is comparison to this risk of 1.0. So everything below this line is a risk less than the reference group. Then we have these 4 data points all represent those who do not meet the recommendations for aerobic exercise, meaning they don't get 150 minutes per week. And then these 4 data points all do meet the aerobic exercise recommendations. They get at least 150 minutes per week of moderate or vigorous activity. And then within that, you have resistance training. None, 1 to 59 minutes, 60 to 149 minutes, and greater than 150. So the worst group to be in is this group. They do no resistance training and no aerobic exercise. But none of these 4 groups meet the recommendation for aerobic exercise, and yet This group especially that gets 150 minutes of a week or more of resistance training, their relative risk is less than half. It's reduced by about 55%. If you look at the group that gets the recommended resistance training and aerobic training, their relative risk is about the same. So this group gets aerobic exercise but does no resistance training. So this is kind of interesting. It's actually better to do, in terms of diabetes risk, according to this study, meeting the recommendations for resistance training only lowers your risk more than meeting the recommendations for aerobic exercise only, which is really interesting. There's other studies that show that resistance training is actually a very powerful tool for managing blood glucose. So I think that that's an important thing to keep in mind, especially for people who are at risk but don't enjoy running or swimming. There are people who would much rather lift weights or do some type of body weight exercises than they would your traditional aerobic exercise, and so that should be encouraged as well. Here's a question that I want you to think about. I'm not going to give you the answer because I want to address it in next week's discussion post, but I want you to think about the role of exercise in gestational diabetes. Based on what you know about gestational diabetes and how it compares to either type 1 or type 2, what do you think? Just food for thought. So this week, you're going to complete your quiz as usual, the last epi in the news, and then don't forget to email me the journal article you want to use for your final project by November the 30th.